Hi, my name is Tomas Kalincik. I'm from CORE and the Melbourne Brain Centre at the Royal Melbourne Hospital and University of Melbourne. And it is my great pleasure and privilege to sit here today at the ANZAN in Sydney 2019 with our distinguished international guest and speaker, Professor Jan Hillert from Sweden, from Karolinska Institute. Jan, you gave fantastic talks at the ANZAN so far, and you will have in another talk that you give tomorrow. And what I see as a unifying theme in your talks is something that we in Australia also very strongly agree with, and it's the fact that there is no longer a discussion about whether we should or whether we should not treat patients with MS. We should not hesitate, we all understand that. But there is another big question, which is currently a hot topic. How should we treat, and how aggressive should we be with our treatment decisions?
Yes, and the reason why it's taken us so long for everyone to have the same idea about the importance of treatment is, of course, that when you develop a drug for a disease such as MS, you're bound to study just the effects of a drug for like 2 years, sometimes 3, but usually 2 years. But MS is a disease, as we know, that you typically have for 30 or 35 or 40 years. And it's a great achievement, to my mind, that we have now been able to collect enough data to show beyond a doubt that this is a useful strategy to improve the long-term outcome of patients. Treatment has a major effect on the outcome of MS. And that in itself shouldn't be neglected. It's an achievement thanks to people like you, us to some extent, and other people collecting clinical data, because that's the only way by which we will ever know whether things we do today have an importance the day after tomorrow.
And do you think that we're doing the job right? We're treating in the right way, or what are the things that we should improve?
Yes. So MS is in a way an unusual disease of the nervous system. It's a chronic, progressive disease for which we have drugs that prevent progression, and makes it a unique disease, more or less, in the field of MS, and one of the major ones at least. So now we have a full dozen of different disease-modifying treatments. And of course the question is, how do we use them in the best way? In combination, in sequence, when should we start, when may we make a stop for a while, etc. How do we minimize side effects? What are the safety issues after many years of treatment? Those are all questions that we haven't yet answered, and that will require work by people such as you and me for years to come.
I may challenge you, or challenge you with a difficult question there, and that is the timing of the most potent of therapies. Because we have, as you said, 12 therapies at various ends of the spectrum of the potency. And the current strategy to treat is to start with relatively safe therapies, either at the bottom range or at the middle range of treatment efficacy, and escalate treatment to more potent therapies only in people who show signs of disease reactivation despite being treated. Is this the right approach, or should we be more proactive? And do you think that we should be going more for aggressive treatment and be prepared to pay some cost in terms of accepting more significant side effects of these therapies early in people's disease?
No, this is one of the remaining questions. I mean, you have to assume, for instance, if you would say no, we can carry on starting even by waiting for some time, and then start with a not so active but very safe drug. We could do that if we had the means of assessing the effects of the drugs, assessing what really happens in the brain. Can we do that? Well, probably not in the perfect way. We have MRI imaging showing when new lesions occurred, but we know that from pathology there are many things happening in the brain that we fail to find on MRI. So we can't really follow what happens if we if you don't treat. So I have a suspicion, or I have a clear expectation from what we already know, that since we cannot assess the totality of what happens, we probably need to be more aggressive from an earlier stage compared to what we have today as the general guidelines, which tell us to start with safe drugs and then, in case of failure, go on with the potentially more dangerous but more highly efficacious drugs. It's the standard of care today is probably more historically determined than theoretically chosen, if you see what I mean.
So in a sense, where there is doubt, we should treat actively.
Given that safety is within reasonable limits.
Absolutely. What we need to obviously improve on, as you said, is the monitoring. And part of monitoring is not just developing new cutting-edge methods to recording information from patients, but it also is the practice of collecting routinely available data that are out there and free to access, like patient clinical characteristics or demographic features. Do you think that we're doing well on that front?
I think that could definitely help. I mean, we are collecting data in clinical practice. That could be used.
Yes.
And there are efforts happening to take care of such data, to record, to compile such bodies of data, although it seems to be frustratingly difficult. But I also think that we cannot do without improved biomarkers, that is blood samples or other kind of tests that will actually show us what is happening. There is an exciting development now in the field of biomarkers that could very well change the way we monitor MS patients.
What are these data good for? You have mentioned two categories of data: the relatively simply accessible data, clinical and demographic features, and the more advanced data such as biomarkers. What can we use them for?
I would say that biomarkers have their greatest benefit in showing the current situation. I think that under indirect, like administrative data, would be more useful as long-term outcomes.
Right.
When we have such data accessible, they can be highly informative. Something that we haven't touched upon, I think, is that the fact that people like you and your network in MS Base, that the rest of us who work with national registries, by doing so, we are actually changing the way in which we assess our patients. We're actually transforming clinical care. Before we started with registries, we wouldn't be as careful in recording disability, attacks, etc. So the mere fact that we document this leads to an improvement of the care. And so before registries were started now 20 years ago, very few clinicians would record a disability score of any kind, if it wasn't in the setting of a clinical trial. Now we do that. Those of us who work with registries, we collect structured information, but we also structure the clinical management. And that in itself is I think, an under-recognized contribution that registries are doing to the MS field. So just by having IT tools that would go in and look for information in clinical files wouldn't necessarily detect information if colleagues, neurologists, wouldn't work in a structured way and document what they're doing. And I suspect they're not necessarily doing that in the busy work situation, very short times to visit for a patient with a neurologist. That's an important thing that I think we need to convince our colleagues to defend. We need to structure the collection and structure the clinical care.
Yeah, it is very reassuring to know that what we're doing is not only having impact on our knowledge base and the information that we have at our disposal when making those important clinical decisions, but also it's something that is feeding directly back to the patient, but through the way of improving the interaction and the patient care. I would like to thank Professor Jan Hillert from Karolinska for sharing his insights with our listeners, and hope to see you at our next interview.
Thank you so much for having me, Tomas.